Okay, guys, we're fixing to do one of the last of the three. Woohoo! We're going to be covering urinary. I'm going to be doing separate PowerPoints. The pediatric, I'm kind of leaving you up to that on your own, just throwing a little bit of information in here and there. So, without further ado, let's get started. Okay, so I'm not going to cover the pediatric chapter, and I'm not going to cover the breast chapter, but I am going to put some information into the PowerPoint. We've already studied breast in physical assessment. We studied some of the breast in the renal, in the oncology lecture that we had, and we talked some about breast in OB. So I really think that we've covered the breast chapter fairly well, with very few exceptions. So Um, I'm just going to do a little bit of coverage for those when I get to the women and men's health. Everybody needs to know what their normal values are for their BUN, potassium, sodium, phosphate, and calcium. Your book lists them in there, and I'll let you look those up as far as that goes, but be sure you know your norms. Um, Kidneys do a lot of work in your body. And they're they're as important as the heart and the brain are. That's why they are one of the three systems that get blood first. They maintain our electrolyte balance. They regulate our acid base. They do reabsorption. They do elimination. They help produce erythropoietin by producing a hormone that causes it to happen. They secrete renin and helps control our blood pressure by converting angiotensin 1 to angiotensin 2. Also secretes aldosterone, which is going to help regulate our sodium and water, which usually helps to elevate our blood pressure in case we have hypotension. It also helps activate our vitamin D, our calcium, our phosphate, our osmolarity, has an antidiuretic hormone, eliminates our metabolic waste. They just do a whole lot of work, and you really should know most of the kidney functions from your A&P course. But if you don't, there's a very abbreviated, I'm not going to go through the actual structures of the kidney, the nephrons, the pelvis, or any of that. You can look that in your in the chapter that covers the A&P of the kidneys. Okay, so first of all, let's start out with disorders of the bladder and the urinary tract. Um, you'll notice I've condensed these chapters down quite a bit, and that's what I intended to do. So, nephrolysis, of course, is our renal and ureteral calculi that form when substances are super saturated in our urinary system. Our most common most common renal stone occurs in the pelvis of the kidneys, and of course we just refer to those as kidney stones. 80% of these stones are made out of calcium oxalate. Then we have the struvite and the cystine. The cystine stones are formed from uric acid. So some of the predisposing factors that come along because of that will make these stones are infection, dehydration, um, some type of metabolic disorder, some type of obstruction in the system, and of course hereditary. If you got bad kidneys in your family, chances are you're going to have a bad kidney. Pain is one of our biggest issues with these as far as this patient goes. But our biggest fear is that the stone will block the urine and cause the urine to be stasis in the kidneys and develop into hydronephrosis. And we don't want that to happen. So we'd really like to get rid of the stones if we possibly can. Sometimes the stones are too big to pass through, and we'll have to go in and do lithotripsy, where sound waves are pulsated through the body and the stones are pulverized and then they pass through. And usually this will cause some bruising on the backside, and that's normal. Patients need to be aware of that. So, in order for us to treat the nephrolysis, we usually do hydration and sedation. We want them to have enough fluids to try to flush that little booger out, but we want them to have pain control so that they don't tighten up against it and it's not as painful for them. Our our urinalysis is going to show an increased specific gravity. We're going to have blood in our urine. We're going to see some crystals in there. One thing that you want to make sure that you do is strain all urine. And of course, if even if they're on IV fluids, we still want to encourage PO fluid. We'd like for them to get up and walk as much as they can, but they may be either in too much pain or have had too much pain medicine to be able to ambulate, so we have to assess that before we get them up. Analgesics are very good. We may have to give them antispasmic medications. We want to avoid any antacids that have calcium in them. We also want to increase the acidity of the urine, and the way we would increase the acidity of the urine would be to add acidic foods such as citrus fruits and things like that that would help increase the acidity of the urine. Dietary restrictions for renal stones are if we have a uric acid calculi, we're going to, which is caused by the ingestion of purine, and actually that's the same as having gout. The alpurinol is what we're going to give for these particular types of calculi. We are going to limit the intake of food that has purine in it, such as organ meats, fish, anchovies, believe it or not, kidneys. I thought that was rather funny. And then the calcium oxalate stones, we're going to limit the oxalate. So we want to limit things such as beets, chocolate, nuts, rhubarb, spinach, and such. Then we have cystitis and urethritis. The cystitis is usually in the bladder, because of cysts being bladder. And it's usually caused by E. coli. Urethritis is also usually caused by E. coli. And the urethritis is infection in the urethra. This is usually considered a sexually transmitted cause, that the urethra was irritated by sexually transmitted disease. We also have interstitial cystitis, which is basically a cystitis that is very hard to detect, and the only way that we can diagnose it for sure is to do a cystoscopy and get a biopsy to be able to tell if it is actually interstitial cystitis. So cystitis has those normal signs and symptoms: increased frequency, urinary frequency, urgency, burning, hematuria. Our UA should show us bacteria, possibly some pus, some cast. Of course, we want to increase our fluids, give antibiotics, maybe give pyridium, which is a drug to help ease the pain of the bladder. It doesn't really help with the infection, but it does help with the pain. Turns your PP orange, so you want to be sure and tell your patients. They can also buy azo over the counter and turns your pee orange, and you need to be sure that they know that. But it does actually help with the pain of urinary infection. And of course, we need to teach them the front to back wiping. Females should void before and after sex. Not to be doing any douching. If you do douching, you will be pushing the organisms upward and onward. Wear your cotton underwear. Avoid tub baths. And of course, cranberry juice, blueberry juice are two of the juices that actually have a lot of antioxidants in it and will actually help with the urinary tract infection. Neurogenic bladder is a bladder that doesn't have any nerve or nerve pathways active to it. Could be caused by diabetes, stroke, vaginal birth, cerebral palsy. Several different things can cause it. We'll have a little bit of bladder control issues with that. A lot of times people that have the neurogenic bladder have to do self-catheterization, so they need to be taught how to do self-catheterization, wash their hands, be sure that they lubricate their catheter, be sure that they wash it when they're done with it. Of course, nowadays we have a lot of the disposable catheters available, so we don't really have to worry too much about it. And then, of course, a lot of bladder control problems. We have the stress incontinence. We have urinary retention. You have overactive bladder, urge incontinence. Urinary retention, of course, is a big problem when we don't empty our urine out, because then we will develop not only cystitis, but we could develop nephritis. So we want to be sure that we are emptying our bladder out. So if we have a urinary retention, we need to figure out why we're having urinary retention and relieve what's causing it to happen. We have sometimes with our overactive bladder, we have a poor control of that sphincter muscle with our stress incontinence. So most of if our incontinence is caused by actual urge or stress, we can actually try to do bladder training with these people that just have no control over their sphincter, and they just cannot control it. We want to do some bladder training, some Kegel exercises, give them anticholinergics like oxybutylene, ditropan, which causes dry mouth. So we want to be sure and offer hard candies. Some of the adverse effects of giving this drug may be blurred vision and flushing. They need to tell their doctor about that. Stress incontinence, we can teach them how to do Kegels. Don't let them limit their fluids, trying to keep from losing their urine. If they avoid caffeine, that helps a whole lot. I know when I drink a lot of caffeine, I have a lot of stress or urging incontinence if I'm not careful. Make myself go bladder train and go to the bathroom. We give a lot for the urinary retention. We may be giving them alpha adrenergic blockers. So we want to be sure that we are paying attention to the side effects, such as decreased blood pressure, dizziness, and things like that. Don't forget with our renal stones, which I did forget, that we should be straining all their urine. We don't need a doctor's order to do that. Then we have bladder cancer. Some of the risks for cancer of the bladder are smoking, occupational carcinogens. Usually the first signs, the symptom that we see of the cancer is gross, painless, intermittent hematuria. We'll have some UTI symptoms and some pelvic pain. The way we treat it is usually with intravesicular chemotherapy, where the bladder is washed with the antineoplastic, and hopefully we will keep them in the bed for as long as we can to let that work. If they have to go to the bathroom, we must terminally clean that bathroom and double flush it. So disorders of the kidneys. Acute glomerular nephritis. We are going to have acute and we're going to have chronic. First, we're going to talk about acute. Acute can be reversed and chronic usually cannot. So, acute glomerular nephritis usually affects kids from age 5 to 15. The most common cause of, it is the most common cause of chronic renal failure, because it goes into the acute glomerular nephritis will eventually, if it continues and we're not able to keep it under control, will result in chronic, which will result in renal failure. It usually results from a previous strep infection, usually an upper respiratory infection. We usually see mild edema, like eyes, feet, and ankles. We see oliguria, and we see proteinuria. We also see azotemia, which is an increase in blood urea nitrogen, which is caused when the kidneys are unable to excrete that nitrogen out. We're also going to see hematuria in our urine. Our goals are going to be to relieve those symptoms and prevent complications. Of course, we have to treat the underlying cause, what caused us to have acute glomerular nephritis. And of course, it's usually the culprit is our strep infection of a respiratory nature. So what we're going to do is we're going to give supportive care. We may have to do fluid restrictions. We have to have bed rest, sodium restriction, make sure our electrolytes are correct. We may be given diuretics to decrease the extracellular fluid. We may be given antihypertensives to help decrease the blood pressure that will be increased with this particular disorder. We have to do strict I&O, daily weight, serum creatinine, bun, and urine creatinine clearance. Their diet should be high calorie and then low protein, sodium, and potassium. And it's very hard to get a diet for this particular disorder that a child between the ages of 5 and 15 will eat. Of course, that doesn't mean that this does not affect adults, because it can affect adults quite as bad as it does children. Chronic glomerular nephritis is a slow progressive disorder. It usually develops from having acute glomerular nephritis that may occur more than one time, so that you're starting to see that you cannot get rid of you can't reverse the acute, and it actually turns into chronic. It's slow, it's progressive, it usually progresses to end-stage renal disease. It may take years for it to do that. Things you're going to see are hypertension, proteinuria, hematuria, same as acute. The very last stage of the glomerular nephritis chronic is mild to severe edema and anemia. It may lead to heart failure. Maintain your serum electrolyte levels. Try to keep your fluids to where the patient's normovolemic, and try to help them prevent infections. We should always be assessing for infection, skin care, high carbs. Make sure they're having a high carbs, low protein. Limiting fluids here, limit the sodiums, limit the potassium, and diuretics as we need them. Pyelonephritis affects women more so than men. It's an inflammation of the kidneys, the tissue, the tubules, the renal pelvis are all infected. Usually ascends from the urethra and bladder and ureters. The culprit's usually E. coli. You're going to have urinary urgency, frequency, burning, dysuria, blood in the urine. But with pyelonephritis, you will also have high fever, chills, and flank pain. That will actually differentiate this from cystitis or urethritis. Of course, we're going to do looking for bacteria in the urine, so we do a UA culture so we'll know which bacteria it is, and to get a good urine sample we should be doing a cath UA if we're going to be doing a culture. Treat it with sulfa drugs, cephalosporin, amoxicillin. All these are nephrotoxic medication, and so we really have to make sure that our clearance rate, our creatinine clearance rate is good enough for us to be able to give this drug without becoming toxic. Risk factors, age, gender, procedures that's been done, possibly a neurogenic bladder from someone who has diabetes or had a stroke. We give antipyretics for fever, although we really shouldn't be giving NSAIDs, because all throughout this chapter, no NSAIDs, no NSAIDs, no NSAIDs, and no aspirin. And then it actually says no Tylenol as well. So it depends on how much damage is done to the kidneys as to whether or not we can give NSAIDs. If we're having pyelonephritis for the first time, there have not been any previous damage to the kidneys, NSAIDs would be fine to use. All urine should be sent to the lab within 30 minutes, or it will grow more bacteria than what it normally would have in it, because the bacteria will continue to grow. Be sure our patients complete their antibiotics. Be sure they're drinking 2 to 3 liters of fluid. They should be resting in between getting up and going to the bathroom or taking a shower, whatever it is. They need to rest in between. Be sure that we're giving them, of course, things for pain, because pyelonephritis is very painful. And again, teach them how to prevent urinary tract infections by the same methods that we mentioned already. Some of the diagnostic tests, this will be the UA. Hydronephrosis is a swelling of the kidney from retention of urine. Most common causes in males are enlarged prostate, females urethra or ureteral strictures, and or renal calculi. If both kidneys are affected, then the obstruction is going to be in the urethra or the bladder. If just one kidney is affected, it will be a blockage in one of the ureters. Can be acute and can be chronic. Um, it's very painful. And the acute is reversible. We usually see colicky pain with that. Some of the symptoms are going to vary. The chronic, we're going to see a loss of the function of the nephrons. It's usually not reversible, and usually the pain is a dull and low abdomen and back pain. So how are we going to treat this? We are going to try to identify and treat the cause, whatever's causing the hydronephrosis, whether it be an obstruction, a prostate, swollen prostate, a stone, whatever it is, we want to get rid of it. We want to fix it. If we can't get rid of it or fix it, we may have to put in a nephrostomy tube. Goes in through the flank area into the renal pelvis, and we shouldn't be clamping it or irrigating that tube. We could actually do a lot of damage to the pelvis of the kidney. If our hydronephrosis has affected our renal function, if it's been going on long enough that our renal function has been affected, our diet should be low in protein, sodium, and potassium. Polycystic kidney disease. We should be avoiding aspirin and NSAIDs with this disease process. It's usually a congenital anomaly where multiple clusters of fluid-filled cysts will enlarge your kidney, and those cysts are going to replace the functioning renal tissue, which is going to develop into fatal uremia. Half the children born to parents that have PKD are going to develop this disorder. There's two main types: the autosomal dominant, which affects adults, and then there's the autosomal recessive, which usually is going to affect the children. Actually, what it does is it affects more in utero, and the babies are usually born stillborn, or they die very early in infancy if they have the autosomal recessive polycystic kidney disease. The autosomal dominant one usually does not occur until, doesn't usually become symptomatic. It's already there, but it usually doesn't become symptomatic until about the age of 40 because it's usually slow growing. Adult PDK has nonspecific symptoms. Hypertension is usually one of them. Polyuria and UTIs. It progresses to flank pain, abdominal mass, hematuria, and proteinuria. We want to do ultrasound, make sure we get a UA. We want a serum creatinine, and we want a bun. Eventually, polycystic kidney disease, the cysts have such an overgrowth that we actually are going to see that they're going to require dialysis or kidney transplant in order to continue living. You have to give them a lot of emotional support and be sure they're getting a creatinine level about every 6 months. One of the two major problems we see with polycystic kidney disease, of course, is hypertension because of the effects it has on the kidneys, and we see constipation a lot with this disorder. We need to try to make sure they have a diet high in fiber and low in sodium to help correct both of these problems that they have. Renal infarctions are very rare. We're not even going to discuss those. Nephrotic syndrome is something that we do have to worry about. It's a major cause. The major cause of nephrotic syndrome is diabetes. African Americans are at a lot higher risk. to develop a nephrotic syndrome, usually because they are at higher risk for diabetes and hypertension, which is what usually leads to nephrotic syndrome. The damage to the glomerular blood vessels that filter waste usually causes leakage of the protein. Could be as much as 3 grams in a 24-hour period. So you have decreased circulating protein in your vascular space, and you have a lot of fluid accumulation in your tissue. So what you're going to see with this is proteinuria, and you're going to see a lot of edema because it's going to be the fluid's going to be going into the interstitial spaces. We need to treat those the underlying cause. Nephrotic syndrome can develop on into chronic kidney disease, which develops on into end-stage renal failure. If your patient has a normal glomerular filtration rate, the person needs to increase their intake of protein. This is one of your few kidney diseases where you're going to see us say increase the protein because the protein actually leaks out in nephrotic syndrome. So you would want to increase protein. We can't increase fluid because we have fluid accumulation. So we're going to have to see, make sure that we may even have to put them on fluid restriction. Clinical manifestations, you're going to have high levels of protein in that urine because it's spilling out. You'll have low protein in your serum. You're going to have a lot of edema, and you're actually going to have some high cholesterol. And those are some things that you really need to be on the lookout for. Renal carcinoma, you should have covered this a little bit, or you should have covered it a lot in oncology. Risk factors are smoking, obesity, hypertension, occupational exposure. There may be some genetic considerations, so it may be familial. If you have renal carcinoma in your family, it could be you need to go be tested to see if you have any of the markers. Renal carcinoma is pretty bad to get. It's hard to catch because it's asymptomatic in the early stages. And then as it progresses, you're going to see hematuria, you're going to see pain, you may see flank masses, weight loss, fatigue, and what we're going to do to diagnose this is ultrasound, CT, and MRI. The best treatment for renal carcinoma is surgical removal of the kidney, a nephrectomy. Radiation we can do, but it's only palliative to try to help decrease the symptoms if the cancer has spread too much. We don't usually do chemotherapy because it's not effective against renal cancer. We do a thing called immunotherapy, where we do immunosuppression therapy, where the natural killer cells can actually try to target the cancer cells. You want to be sure that you're doing pre-op and post-op care. You're going to teach what you're going to do, and then you're going to be sure and for preoperatively, and then you're going to do postoperative care just like you would any other recovery, except you're going to have to be very vigilant about blood pressures, making sure that we're protecting that remaining kidney, and teach the patient, not to be out doing anything drastic activities that will have to be, he can't get into rough play and has to be very careful with that. We want to make sure they've got adequate hydration, I&O, and of course with just one kidney functioning, we want to make sure we're not giving medication that's nephrotoxic, and if we do have to give nephrotoxic medication, we want to be very careful about our dosages with that. Then we have acute renal failure. Acute renal failure is one of our big things, especially in the hospitals, because most of your acute renal failure is caused, as usually happens in the hospital, to patients who are ill and have a suppressed immune system. So actually, what we do to help fix it is correct the underlying cause. We can give diuretics to these patients if they're having oliguria and their cardiac output is adequate. We give them antibiotics, but we want to be very careful again about giving antibiotics. Very carefully make sure we're monitoring vital signs, daily weights, I&O, Be sure our urinals, within easy reach of the patient that's having acute renal failure, because we don't want them to be moving around too much. In acute renal failure, we're going to see some tubular necrosis, and this is going to account for the majority of the illnesses, acute kidney illness that we see. Um, because of this necrosis, it prevents normal concentration of urine, the filtration of waste, prevents regulation of acid-base balance, and causes electrolytes and fluid balances to be off. So they can be caused by toxic injury or ischemic injury. The toxic injury is caused by nephrotoxins. This could be drugs, chemicals, bacteria. So it could be the antibiotics that you're giving them. It could be anything that's going to cause any drug that excretes through the kidney, that the kidney cannot excrete out. It's going to be dangerous to the rhabdomyolysis, cephalosporins, aminoglycosides, PCP, and heroin are all toxic injury causatives. Ischemic, of course, has to do with your perfusion. So this is when your perfusion to the kidney is severely reduced. It can be done by having hemorrhage, severe dehydration, cardiogenic shock. So again, this usually occurs in critically ill patients. The effects of the primary disease may mask a lot of your symptoms. We have 4 phases of acute renal failure. We have the initiative, which is where the very beginning of it, where just our glomerular filtration rate is down. Then we go into the oliguric phase, which is you have a larger decreased glomerular filtration rate. Then we start seeing an increase in the BUN and an increase in the creatinine. This patient, we may see an increase in our mortality rate. We can also have a non-oliguric phase where the output of the urine is normal, but we still have the other symptoms. So it can be either no urine, oliguria, very little urine, or it can be non-oliguric, but it will still show the same things. Then you have the diuretic phase. So after it goes through the first 2 phases, it goes into the 3rd phase where we start seeing diuresing starting to happen, and then our glomerular filtration rate is going to naturally go up. And we're going to see polyuria because we're going to be diuresing. And once we start diuresing and getting rid of all the fluids and our system starts going back to normal, we're going to see a slow recovery back to normal, and that's our recovery stage. We definitely have to maintain our fluid balance in these patients. Excess fluid volume is very common. We want to be sure we're doing daily weights. I know, listening to breath sounds, being sure we're assessing for over hydration, and make sure that our sodium and our potassium is low, or our intake for that is low. We also will have renal failure when our kidneys are unable to clear the blood of the urea and the creatinine. They'll go into uremic syndrome, which will go into end stage. They should always be in the hospital if they have acute renal failure, so that we can monitor them very closely. So most of them are already in the hospital, as we said before, but it develops very suddenly, and it can be reversed as long as we are able to treat it, recognize it, and we treat it. If we don't treat it, the patient's going to progress to end-stage renal disease, the uremic syndrome, and death. So sometimes even when they're in the oliguric phase and they're having a lot of edema and they're holding fluids and putting out very little fluids, we can give them Lasix, and it usually doesn't work very well for them. And it's just because it's in the oliguric phase, it's just not going to work. So usually we're going to be seeing that decrease in the urine or no urine, and we're going to be seeing that bicarb deficit. When we start seeing a bicarb deficit, we're looking at some metabolic acidosis. Then we have types of renal failure: pre-renal, intrarenal, post-renal. And the rifle is just an anonym that they give you in your book that I thought is a very interesting way to sum up what happens with acute renal failure. Pre-renal is anything that happens before the kidneys, which things like the blood supply. If that blood supply is interrupted before it gets to the kidneys and it doesn't get there, that's pre-renal. So diminished blood flow, hypovolemia, sepsis, emboli, even severe nausea and vomiting, which can cause dehydration, can lead to pre-renal acute failure. Intrarenal is when the damage is directly done to the kidneys. It can be actual trauma to the kidneys. It can be glomerular nephritis. It can be lupus. It can be your nephrotoxins. And then, of course, your post-renal is anything that happens below the kidneys. So if it's something that obstructs the urinary flow out of the kidneys, it's post-renal, if that's what's causing it. Usually it's bilateral obstruction of the urine outflow. The rifle goes through. I'm gonna let you look that up in look at it in your book. It just tells you what categories meet risk, injury, failure, loss of function, and then the end stage. So it's just interesting in how they divide that up in the glomerular filtration rate and the serum creatinine rate. The serum creatinine and your GFR are your two major markers in kidney failure. Acute kidney failure, of course, some of the early signs are oliguria, azotemia, anuria, and then as you become more uremic, as the urea is not filtered out of the body, you're going to have some irritability, some confusion, going to have pruritus from uremic frost being there. You're going to see a reduced tubular hydrogen excretion and a decrease in the bicarb reabsorption. And that's going to result in your metabolic acidosis, where you're going to see some small respirations going on. You may see some severe hyperkalemia. It's something we really try to keep a watch on, because if we're not secreting out our waste, potassium's not going to be excreted out, and we're going to get a development of hyperkalemia. This can cause dysrhythmias, cardiac arrest. A high T wave is going to be indicative hypernatremia, or hyperkalemia. Then we will see possibly some hyponatremia and fluid overload going on as well. As our kidney failure progresses, our glomerular filtration rate, of course, goes down and our serum creatinine goes up. We should do a 12 to 24 hour urine to determine our creatinine clearance. Our normal for creatinine clearance is 85 to 135 mils per minute. Anything less than 40 is moderate to severe renal damage. When we do a creatinine clearance, we should always have a height and weight included in that so it can be figured accurately. So how are we going to manage our acute renal failure? Well, your book pretty much spells it out for you. The fluid balance, and the way we do that with cyanone fluid restriction. Maintain that protein intake. We may need more, we may need less, so it depends on what usually our albumin level is. If our albumin level is low, we need more protein. If it's high, we need less protein. We should be meeting enough calories to maintain the desired weight that we want. Most of the time our potassium is going to be hyper. We need to know how to treat that, and usually we treat that with hypertonic glucose solution with insulin, IV calcium gluconate, or chalaxylate. So we can use all those things. We may have to adjust dosage of medications because the renals are not filtering them through, and we may be getting a toxic buildup. Of course, we want to avoid those NSAIDs and antacids with magnesium. So, we really want to be sure that we know the signs and symptoms of fluid overload, because that is what usually occurs. And just like we need to know the signs and symptoms of hyperkalemia, because that is usually what occurs. You usually don't see it opposite. So one thing we can do is continuous renal replacement therapy. Now this is a mode of dialysis, but it's not hemodialysis and it's not peritoneal dialysis. It's just a type of dialysis where we have access in and access out. When we use in a hospital setting, usually in ICU, we don't want to do this anywhere else. Going to remove that solute, and we're going to do it slowly and continuously. So there's less chance of them having complications from a rapid removal. So some of these, I just put the terms down there y'all really need to look at. There's different forms of the continual renal replacement therapy. Basically, the reason why we would give this, if we have hypervolemia, we need to get out some fluids. If we have hyperkalemia, we want to get out the potassium. If we have a really severe BUN or creatinine that's high, or metabolic acidosis would be the reason we would use this as a quick dialysis to use. So how are we going to manage ourselves for this patient? It is very critical to monitor all of these things. The fluid balance. We cannot let them get an overload. Sodium intake should be limited to no more than 1,300 milligrams per day. Protein intake should be calculated per kilogram. If they're on dialysis, it should be at least twice as much as that if they're on dialysis. Dietary potassium should be 20 to 50 milliequivalents. I hope I said protein for that 0.8 instead of potassium. I was looking at one and thinking about the other one. Also, the erythropoietin, we need to be sure that we are enhancing erythropoiesis by keeping we may have to give erythropoietin injections to our patient to help produce red blood cells. Phosphate, we may have to reduce that because it doesn't always filtrate out. So basically, I know in daily weights on every patient that has a kidney issue is very important. If we put them on fluid restriction, usually what we let them drink or the intake of the fluids is going to equal whatever urine output they have plus 500 to 750 milliliters per day. So if they put out 500 mils of urine, they could have 1,000 to 1,250 milliliters of fluids all day. And we have to make sure we do all body fluids. If they have a draining wound, we need to weigh the dressing and make sure that we are counting that fluid as being out. They should have a high calorie, adequate protein, and low sodium, low potassium. They're very susceptible to infection, so we need to be using aseptic technique. Be sure we're washing our hands very well. Our nursing assessment, when we get a verbal history, we don't want to make sure whether they're having frequency, how much they pee, if they're having headaches, what color's their urine. And physically, we want to check all the rest of the stuff out ourselves. These are our objective information. And of course, some of our diagnoses for these patients are risk for infection, risk for injury, and the biggest one, of course, is fluid volume excess. So be sure that you are aware of how to assess for fluid volume excess. Then we have the interventions that we're going to do. So some of the most important interventions that we're going to do is that we're monitoring our electrolytes in our labs. We're monitoring cardiac arrhythmias by doing EKGs. If they don't, if they're having hyperkalemia, they're not excreting potassium, they're definitely going to be having those arrhythmias or dysrhythmias. So we need to monitor that potassium. If they have a hyperkalemia, we need to administer 50% glucose with IV insulin because it will transport potassium into the cells, hopefully. We can also give them calcium gluconate IV, and we can give them KXL8. And I think I've already said that to you once, but I'm saying it to you again. Signs and symptoms of fluid overload, we're watching for weight gain, so that's why we keep saying be sure we're doing daily weights. your hypertension, be sure you're doing those vital signs. Tachycardia, listen to those breath sounds. Any type of peripheral edema, and of course, if we start seeing a low hematocrit and a lot of edema going on. We need to be sure that we're doing really good mouth care with these patients. They're on fluid restrictions. They're definitely going to feel thirsty. We can give them diuretics and vasodilators to help maintain some of their cardiac output. Be sure we're watching for signs of infection, and be sure we're giving meticulous skin care. Then we have chronic renal failure. Chronic renal failure is not reversible. It's the progressive loss of kidney functions. Your renal capacity actually gets down to 10 to 15% and goes into the end stage. What causes this? Chronic renal failure, diabetes, hypertension, urinary tract obstructions, chronic glomerular nephritis, and other infections of the kidneys. So anytime you have someone with chronic renal failure, you always want to monitor all your drugs for toxicity. You want to make sure that you know what those tox levels are. Know your signs and symptoms of digitoxicity, because that's one of the drugs we normally will give to these patients. They have high risk factors are the African American male, their age, and heredity. So these are things that you want to watch for. If they develop uremia, they're going to develop metabolic acidosis, and they're going to develop small breathing. End stage renals, you're going to be seeing those tall peak T waves. That's going to be telling you about the hyperpotassium. Some of the manifestations that you're going to see is fatigue, anorexia. They're going to be nauseated. They're going to be vomiting. They're going to have metallic taste in their mouth. They're going to be irritable. They're going to have some muscle cramping. They're going to have pallor, dry skin, and of course the hypertension and the edema. Treatment is to just slow the progression down, because we can't reverse it. So our goal is to slow that progression down by treating the underlying cause. It could be drug toxicity. It could be diagnostic contrast that affected our renal function. We want to avoid any of those drugs that may lower our GFR, such as NSAIDs, aminoglycosides, and antibiotics. We definitely need to control the hypertension. If we don't control the hypertension, we have more and more damage done to our kidneys. A lot of times we give ACE inhibitors to help with the hypertension. It decreases glomerular pressure, and we want our blood pressure to actually be no more than 130/80. Our nursing management, again, is to slow the process. Education should begin at the time they got the underlying cause, such was the diabetes, the hypertension. We should be doing prevention by helping them keep that into control. But a lot of people do not believe that they're going to see all this damage be done to them, because they can't see it as, so I'm sitting here, I don't see the damage to my kidneys. I don't see the peripheral neuropathy. I'm into neuropathy in my feet. So, people that are definitely not into nursing really don't understand the importance of doing that. So when we have hyperkalemia, we already talked how to treat that. If we have metabolic acidosis, you want to treat that with sodium bicarb. If they're anemic, we want to make sure that we are trying to help increase the production of erythropoietin and give them iron as well. If we don't increase the erythropoietin, that increase the amount of blood cells, it doesn't do much good to give them more iron for what blood cells they've got. These patients have a tendency to bleed because of the process with the red blood cells. they have to at some point make a decision whether they want dialysis or if they want to do renal transplant for quality of life. If they decide they want to go on hemodialysis, they have to keep in mind that they're going to have a restriction of certain nutrients and that the hemodialysis is going to remove some waste, and it's only effective if that patient actually if that patient actually is compliant. So we can do maintenance dialysis, we can do hemodialysis, peritoneal dialysis, kidney transplant. These are all of our choices when we get to the point where our kidneys aren't working like they should. To do hemodialysis, we have to have vascular access. Usually an AV fistula is usually has fewer complications with it. We have to have an artery and a vein. We have to wait until it matures. It can require months before we can use it. If it's not usable, if it's gone bad, we won't feel the thrill. We won't hear the bruit. The hand may be cold and painful. We should not be using those particular AV fistulas if we're doing that. Of course, no blood pressures or labs in the arm that it's in. With the hemodialysis, we may develop dialysis disequilibrium syndrome, which is a rapid decrease in the fluid from the body because the dialysis may pull out too much of the fluid. Our BUN and our decrease in our BUN, and this can cause us to have cerebral edema and increased intracranial pressure. Convulsions are possible to follow, so you want to be sure to be prepared to give anticonvulsant to these patients that are on hemodialysis that may have this actual reaction there. The peritoneal dialysis basically is where you put it into the peritoneal area. You put sterile dialyzing fluid through a catheter, and it's going to bathe the peritoneal membrane, and then excess fluids and solutes should come out. You should have out about the same of what you put in. If you have more, it's called positive fluid balance, and if you have less come out than what went, if you have more come out than what went in, then it's negative balance. So that means that if you have more go in than came out, they have more fluid in than out, so that's a fluid balance is positive for them. And then if you have more out, we've created a fluid balance negative. And each time that this happens, we have to report that. We can do continuous or intermittent. The amount and dwell time, of course, is decided by your healthcare provider. You always want to have a baseline vital sign and weight before and after you do a peritoneal dialysis, and always use aseptic technique and try to make sure that your fluid is body temperature, and make sure when your fluid comes out that it is not cloudy. If it's cloudy, it may be peritonitis. Peritonitis is a big complication of peritoneal. Usually when they're on dialysis, they need more protein. So this is one where we're going to increase their protein diet. Since we use anticoagulants for the hemodialysis, we want to watch for excessive bleeding. So you need to know what the antidote for heparin and warfarin is. Usually with, we're going to be given protamine sulfate as an antidote for that. Kidney transplant, our biggest problem with that is we can have rejection. We can have acute rejection, or we can have chronic rejection. Acute rejection is where you have oliguria, you're going to start running a fever, they become lethargic, and they start having all the symptoms of increased serum, creatinine, and bun is up, and potassium. You can reverse this rejection with aggressive immunosuppressive drugs if we get to it in time. If they have a chronic rejection, we cannot reverse that very easily. Usually a transplant is your treatment of choice because it improves the quality of life and reduces mortality. It reverses many of the complications that develop because of renal failure. Hypertension goes down. They get out of metabolic acidosis. Everything kind of just goes back to a normal. It actually costs less than having dialysis done. And there's also a big risk for infection because they are on those immunosuppressive drugs. So we're figuring out how do the elderly, how do them being elderly affect this kidney disease process. If they're older than 65, they have the highest incidence of kidney issues. They have smaller kidneys. Our glomerular filtration rate has decreased from the time we got 30 all the way, from the time we got 30 years old, all the way up to where it's working only at 50%. Then, of course, we have other disease processes such as the diabetes, stroke, MI, and all those things. And then, of course, we have incontinence because they have a decreased bladder capacity, maybe decreased muscle tone. Men may have an enlarged prostate. A lot of those things are going on. Sometimes we'll have the older women have a decrease in hormones because of menopause, which causes them to have thin vaginal mucosa, and that's going to increase the number of cystitis infections that you're going to see in the elderly. And some just information I want to just kind of quickly go over is that with NSAIDs, where we want to be sure we avoid them because they're nephrotoxic. Alpurinol for the uremic stones. Levaquin, we use that sometimes for cystitis. It can actually cause cardiac arrhythmias, so we want our patient to take their pulse twice daily. We can actually give Cipro for cystitis for just a 3-day treatment, and it will be effective. Amoxicillin, any type of antibiotic, will disrupt birth control, so you need to teach your patients that are taking just birth control pills that they need to use a different type of birth control while they're on antibiotics. A lot of times with your neurogenic bladder, self-catheterization has to occur, so you want to be sure that you are being, you know how to teach them that they should wash their hands before and after, lubricate their catheter. If they're not using disposables, they need to wash their catheter with soap and water, rinse it well, and then store it in a plastic bag to keep it clean. And that, my friends, is the end of that.